Bom, então estamos aqui no TMOCast com a doutora Ana Sureda. Eu sou Samir Naban, de Curitiba. A doutora Ana veio mais uma vez ajudar a gente a discutir as indicações de transplante para os pacientes com linfoma não Hodgkin e linfoma de Hodgkin. So welcome, Dr. Sureda. Thank you once more for coming for the SBTMO Congress. It's a pleasure to have you here this year. And we just got out of 2 different sessions talking about those indications. What do you think it's the most important message that we had during those talks?
So first of all, thank you very much, Samir, for the invitation and to participate in SBTMO and also in this podcast. I think that the most important messages from the sessions that we have already participated would be autologous transplant. It's still, I would say, that the standard of care for patients with classical Hodgkin lymphoma that relapse if they achieve a metabolic complete remission. The role of allogeneic stem cell transplantation probably is dedicated to those patients with multiply refractory disease. Maybe in the near future, we will see data that will allow us to avoid autotransplant, at least in some patients with relapsed refractory disease. If we talk about non-Hodgkin lymphoma, there is clear evidence, at least from the European registry, and I guess that this is quite similar to the American registry, that the numbers of basically allogeneic stem cell transplantation are decreasing, not only for relapsed refractory diffuse large B-cell lymphoma, but also for mantle cell lymphoma and follicular lymphoma. And allogeneic stem cell transplantation is being substituted by novel drugs or eventually other more intelligent and targeted cellular therapy strategies.
Yeah. I always think about, we were talking during these sessions about new mechanisms of actions, eventually immunotherapy, CAR-T and everything. And we always have a problem with the transplant studies because those drugs or those technologies, they have the industry back them and the randomized trials are made in an easier way. And we always suffer a lot to do a prospective randomized trials with transplant indications, even for autologous or allogenic. How can we use those different levels of evidence from transplant and new mechanisms of actions to take our decision? What do you think about it?
Well, I think that you have made here the point. Unfortunately, for transplant, we suffer because we don't have prospective randomized clinical trials in most of the cases. Many of the prospective clinical trials were done many years ago with population of patients that we don't have nowadays because first-line treatment strategies have also changed a lot. And I think that targeted therapy in general has the option, because of the strong industry support, to be implemented and developed in the setting of prospective clinical trials. Maybe the best way, I'm not an expert on that, but one of the ways that we can use is to use sophisticated statistical methodology to try to compare the different strategies. For instance, nowadays there are quite a lot of studies that have used propensity matching scoring systems, where you try to avoid heterogeneity between 2 populations of patients and then try to compare face-to-face 2 different strategies. Even with that, I have to say that this is not 100% the best way to do things. This should not be the golden rule, but at some point in time, this is the only, probably the best way to do this type of comparisons. The other thing I want to say is that when we talk about transplant, we are basing a lot our evidence in registry-based analysis. And by definition, registries are not capturing those patients that had eventually the intention to go into transplant and that for whatever reason the patient could not reach the transplant. So we always have to think that the data that we are presenting from registry probably are overestimating the efficacy of the treatment, because we have basically forgotten, or we have not included those patients that never reach the treatment.
Yeah, we here in Brazil, we have like a very different perspective if we work in a transplant center or we don't, because access is even difficult for a bed if you want to do an autologous. Many patients with diffuse large B-cell lymphoma struggle to go to an autologous stem cell transplantation in the public services because they don't get the timing correct. They are in a complete response, but they don't get the bed, and then they relapse and they do another rescue protocol. So if we are in a transplant center, we see patients with a better results because we do this inside our hospital. It's faster, it's easier. But what lacks is that people that look at the results of the transplant, they are not taking in consideration that with the new mechanisms of actions, people will have the results better than what we published, because you finally can take the patient in a good quality of response to do the transplant. So as a transplant doctor, this is something that I always try to convince, that we cannot say no for a potential curative treatment only because like we have like 1 year follow-up with good result with a new drug. This is something.
So I fully agree with that. In fact, I am a transplanter, and I think that transplant is a curative treatment strategy for a significant proportion of patients. The problem with transplant, first of all, is the side effect profiles of the treatment itself, not only short-term side effects, but of course long-term side effects. And the other problem with transplant is that many patients cannot reach the transplant for several reasons. And one of the reasons is that it's very clear that results of transplants are significantly improved in those patients that go into transplant in a complete remission or metabolic complete remission in some of the cases. And I think that nowadays we have the possibility, first of all, to increase the reach of the patients to transplantation, and second, to improve the results of autologous stem cell transplant with the use of new drugs. And for the time being, we have quite a lot of information indicating that this combination targeted therapy that has a different toxicity profile from stem cell transplantation, that it's very effective, can eventually increase, first of all, the population of patients that are candidates for transplant, and second, the results of autologous stem cell transplantation itself.
Yeah.
For instance, one example which I think is very interesting. So in diffuse large B-cell lymphoma, autotransplant is being partially substituted by the use of CAR-T in those patients with early relapse or primary refractory disease. But the major reason why these patients are doing not so well with an autologous stem cell transplant is because the current salvage strategies that we have are not good enough to put these patients in complete remission, and we are not taking them into the autologous stem cell transplantation. When bispecifics are being moved effectively to second-line treatment, and we have data from prospective clinical trial that are basically supporting what I am saying, the metabolic complete remission rate of these new salvage strategies is going to go significantly up. And in this sense, we will be improving the results of autologous stem cell transplantation, not only with more patients being transplanted, but the results of autotransplant are going to be improved. And just because of the difficulties with CAR-Ts, maybe the role of autologous stem cell transplantation is going to be rejuvenated or increased, at least in some areas where CAR-T are not so easily accessible, with the introduction of new drugs with the old salvage chemotherapy protocols.
Very good. Very good. Thank you so much for all your participation here. I think we had a very productive time with you. Thank you, Dr. Sereda.
Thank you very much. Thank you for the invitation. Thank you.